now I'm going to turn it over to Estie Rose. She's genetic counselor and outreach coordinator for the JScreen program. Prior to joining the JScreen team, she held a clinical position as genetic counselor at the Montefiore Medical Center, where she focused her practice on reproductive and cancer genetics. She also served as instructor at the Albert Einstein College of Medicine and was an integral part of its program for Jewish genetic health. She has a special interest in community education and outreach and is proud to be a resource for individuals of her community who are facing genetic health issues. She has been a certified genetic counselor by the American Board of Genetic Counseling since 2010. Now I'm going to turn it over to Estie.
Hi, everyone. I'm just going to share my screen. Give me a moment. Oh, you need to allow me to share my screen, Melissa. Okay. Can you see my PowerPoint? Yeah. Okay. Well, it's nice to see everyone here. Hi, everyone. So as you heard from Melissa, I am a genetic counselor with JScreen, and you heard a little bit about our program through Rachel and Alex. But today I'm going to give you basically an overview of what genetic testing is, what we do when we do reproductive carrier screening. I'm also going to throw in a little bit of information about a cancer genetic test that we do at JScreen. And at the end, we have plenty of time for question and answers. So if anybody has a question, they can post it in the chat box, and it will be monitored throughout the talk. So I will start now. So a little bit of an introduction to genetics and genetic testing. So many people have no idea what a genetic counselor is. So I just wanted to introduce you to the field and to the career of genetic counseling. Very often after I explain what we do as a genetic counselor, I find people who are interested in going into this field. So if this would apply to you or anyone you know, I think it's a really, really wonderful field. And I'm so happy with my choice, my career choice. And I'm so proud of what I'm able to do for my own community. So genetic counselors have a master's degree in genetic counseling. It's a 2-year program. And in our schooling, we learn a lot of clinical genetics. So it's a lot of classroom stuff, about genetics and science and biology and physiology. But in addition to that, we're also learning how to be a counselor, how to counsel people through hard times. Even though most of our patients have good news, sometimes it's not good news. And we need to know how to talk to them appropriately and in a way that is sensitive and appropriate. So that's a really big part of our training. As a genetic counselor, our job is to try to assess what's going on when we suspect that there could be something genetic going on. So let's say, for example, in the prenatal realm, somebody does an ultrasound and they see something abnormal in the baby. Maybe it's something genetic. In the pediatric realm, let's say a child is not meeting the milestones they're supposed to be meeting at that point. Or let's say they have specific facial features or other physical features that are suggestive that there's something genetic. In the cancer realm, you might see a lot of people on the same side of the family with the same types of cancers over and over again, or maybe getting cancer at a really young age. These are just a couple of examples of different places or indications for genetic counseling. But overall, what we do is we try to explain to our patients why we think or suspect that there could be something genetic going on. Then we talk to them about the testing that's available for them for those specific things. And then when the results are in, we speak to the patients about what they mean for them and also for their family members. So it's a lot of talking, it's a lot of educating. It's basically like being a teacher in a classroom, but doing it one-on-one. So you're being very individualized for the patient to try to get to the bottom of things and to try to figure out whether or not this is something genetic. So as I mentioned earlier, I'm so happy to be part of this field, and I'm happy to speak to anybody who might be interested or know somebody who might be interested in joining the field. It's really, really wonderful. Okay, so genetics 101, don't worry, I won't test you on this after we speak. This is some stuff that you might remember from 9th or 10th grade biology, maybe not, but I'll give you a quick recap, a quick reminder. Our genes are made up of DNA. So you see behind Melissa and Sarah, there's a double helix. That's a picture of our DNA. And our DNA is made up of different nucleotide bases. They're called adenine, thymine, guanine, and cytosine. Not really important what they're called. We just call them A, T, G, and C for short. Every single one of our genes, and we have about 30,000 genes. So every single one of our genes is some kind of a combination of these 4 different bases. And we have a picture of what every single gene is supposed to look like. So what a normal working copy of each and every gene looks like. And it's always a combination of these A's and T's and G's and C's. Now, you need the gene to look exactly right in order for it to function properly, in order for it to work. If it doesn't look exactly right, if there's some kind of a difference or a change in any of these 4 bases, that could potentially be problematic. So if there's a change, either that could be associated with a disease, meaning the change causes the gene not to work, and that would be called a mutation. Or the change could be benign, because not all change in our genes is necessarily bad. It's not always associated with a disease. Earlier, we were joking about curly hair. You know, some people have curly hair, some have straight hair. That's due to genetic changes, but it's not bad to have one type of hair versus the other. So a change is not always a mutation. It's not always related to disease. Sometimes it's just benign. The third type of change in a sequence is not something that's not well understood. We call it a VUS, which is short for variant of uncertain significance, which basically means that there's a change in the gene, but we don't quite know whether it's benign or whether it's actually related to disease. We're not going to go into too much detail about that now. I just wanted to put it out there because people hear about VUSs and ask me about them all the time. But again, nothing to worry about right now. So when we're doing genetic testing, what we're doing is not to look to see if somebody has the gene. I know we all have all of the genes, but rather we're looking at the bases of the gene, these A's and T's and C's and G's, to see whether they look right, to see whether they're in the right place and filling up the gene the way it's supposed to. There are 4 different types of positive results that somebody can get on genetic testing, and it really depends on what type of genetic testing you're doing. So the first type of positive result is a diagnostic result. So you're testing somebody who you think might have a genetic disease. And a positive result means, yes, there's a mutation or a change in the gene that we know is associated with that disease. So when somebody tests positive on a diagnostic test, that means that they have the condition. So, you know, I would counsel my patient, you have Usher syndrome because you have these mutations, or you have Marfan syndrome because you have this mutation. Another type of positive result is when we're testing somebody not to see if they have a disease right now, to see if they have symptoms of a condition today, but it's predictive or pre-symptomatic testing. So you're testing them for a gene where if somebody has a mutation in that gene, they might not have symptoms now, but they could potentially develop it in the future. So a common example of this type of testing is Huntington's disease, which is a pretty severe neurological condition. So when people get tested for it, usually they get tested at a young age because they know they have a family history of it. And we're not testing them to see if they have Huntington's, it's to see if they're going to get it when they get older. Another type of positive result you can see is predisposition testing. Predisposition testing means that you don't have the disease now. You might get it later, but you might not. So you have a genetic predisposition to it, but it's not a guarantee as it is in this pre-symptomatic testing. So you might get it, you might not, but you certainly have some kind of a change in your genes that would predispose you to the condition. So breast cancer is a really good example. If somebody has a mutation in one of the breast cancer genes, it's not a guarantee that they'll get breast cancer, but their chances are higher than other people who don't have a mutation to get breast cancer. The last type of positive result that we're talking about, the one that we're going to focus on today, is an unaffected carrier. When somebody is an unaffected carrier, they themselves don't have the condition, but their children could potentially have it if both they and their partners carry it. So carriers generally have no symptoms. It is not a pre-symptomatic kind of test. It is not a predisposition kind of test. It is not a diagnostic test. They don't have the condition. They'll never get the condition, but their children could potentially have it if their partner happens to carry it as well. And this is what Rachel and Alex were talking about before with the JScreen test, which we're going to focus on a lot more. Other possible results that you can get from genetic testing are negative results. Those are always good. Negative results mean that there is no finding. Sometimes, or most of the time, people are very relieved to get a negative result. But it is important that even with negative results, when you do genetic testing, a genetic counselor should be there to interpret the results in the context of the family history and the personal history of the person. So it's not just good to say you're negative, you're good. You have to explain the limitations of the testing and what this means in the context of your family. Another possible result I mentioned earlier, those are uncertain results where we see a change, but we don't know exactly what it means. Those could be a little bit frustrating to get. And every now and then with genetic testing, we'll have incidental findings where we sometimes find out more than we were actually looking for. And we're a little bit surprised by information that people don't have a history of or a family history of. And then all of a sudden we see a positive result that kind of seems like it came out of nowhere. And this happens every now and then. But again, today we're going to focus on the unaffected carrier type of positive results. So this is about reproductive carrier screening. So Melissa mentioned this, sorry, not Melissa, Rachel mentioned this a little bit earlier. When we're doing our carrier testing, we're looking for recessive conditions to see if people are carriers for them. As I mentioned earlier, when somebody's a carrier, they do not have symptoms. They will never get symptoms of that condition. They are totally healthy and have no idea, just like Melissa had no idea when she and her husband were carriers for Usher-1F. The only time you could know whether you're a carrier or not is A, if you do genetic testing and you find a positive result, or B, if you have a child who's affected, which clearly happened because working backwards, both parents are carriers. So this is a picture of a Punnett square, which you might remember from back in the day. When you have a carrier couple, when both the man and the woman carry the same condition, every time there's a pregnancy, there are 4 possibilities of what can happen. Either the child will be an unaffected non-carrier, or they'll be a carrier, that's this one and this one, or they'll actually be affected with the condition, and that's what happens when both parents pass down their mutation. So in other words, every time a carrier couple gets pregnant, there is a 1 in 4 chance for the child to inherit both mutations, one from mom and one from dad, and to actually be affected with that condition. So I know a lot of carrier couples who've never had a child who's affected, and I know a couple of carrier couples who have more than one child. Melissa mentioned 2 out of 3 of her kids have it. So it's not 1 in 4, like if you have 4 kids, one of them is going to have it. Rather, it's per pregnancy. So anytime there's a pregnancy, there's that 1 in 4 chance. And what happened in past pregnancies and what will happen in future pregnancies have absolutely nothing to do with it. It is 1 in 4 each time there's a pregnancy. 80% of babies who are born with heritable genetic diseases have no family history. So very often, or most of the time, it's a surprise when a child is diagnosed with a genetic disease. And the reason is because the parents are not affected, right? They don't have any symptoms. So the carrier status has been going on from generation to generation to generation, but the disease has never come out, right? Because it's not that likely or not that common for a carrier couple to get together. So most of the time, when somebody does have a genetic disease that's running in the family, it's not really running in the family, meaning the disease is not running in the family, but only the carrier state is, and usually it's invisible and people don't know. Most people that we test at JScreen are going to be positive for a couple conditions, especially if they have Ashkenazi ancestry. And I know Rachel was, very wise to mention that she has complete Ashkenazi ancestry and Alex has half ancestry. That's Ashkenazi. The more Ashkenazi you are, the more likely you are to test positive. So most people who we test do end up being carriers for 1 or 2 or 3 things. It's usually even more than 1. And because of that, it shouldn't be seen as a stigma for somebody to be a carrier. It really, like, we're all carriers. I tell people, you're not doing the genetic testing to see if you're a carrier. You're looking to see what you're a carrier for, because really all of us are carriers and it's pretty much expected that everyone's going to be positive, especially people who have a lot of Ashkenazi ancestry. Oops, sorry. So some of the conditions that we test for are ethnic specific. And when I say ethnic specific, I don't mean that these conditions are exclusive to people of this ethnicity, but they're much more commonly seen in people of that ethnicity. So people here might have heard of the condition called Tay-Sachs disease. I know Melissa mentioned it earlier. That was kind of like the original genetic test that we've been doing in the Ashkenazi population. It's common in Ashkenazis, but it's also common in other ethnicities like French Canadians and Louisiana Cajuns and even the Irish population. Sickle cell disease is another genetic condition that's common in the African American population. And there are also diseases that are common in Sephardic and Mizrahi Jews. So while these conditions are more commonly seen in these ethnicities, they're not exclusive to them. So that's very important to know, because back in the day of genetic testing, people would only screen based on their ethnicity. So if they told their doctor, I'm Ashkenazi, they'll test you for Tay-Sachs. If you don't tell them that, they won't test you for Tay-Sachs. And now we're learning that that's probably not the most responsible way for doing testing, because carriers will be missed if you're targeting the testing only on someone's ethnicity. Because anybody can be a Tay-Sachs carrier, even though it's more common in Ashkenazis. Again, it's not exclusive. So anybody could be a carrier for anything, just some conditions are more commonly seen in people of certain backgrounds. Usher 1F I'm using here as an example. So this is a carrier rate chart that I got from Myriad Genetics. That's the lab that we use. Here they list out the carrier rate of being for Usher 1F in people of different ancestries. And you can see that the most common rate is for people who are Ashkenazi Jewish. So about 1 in 80 Ashkenazis is a carrier for Usher 1F, and it's much less common in people of other backgrounds. Again, it's less common, but that doesn't mean it can't happen in people of those backgrounds. And that's why everybody should get tested, regardless of their background. It's not only for people who are Jewish. So when we find carrier couples, which doesn't happen that often, most of the time we see carriers, but not carrier couples, we counsel them about different options that they have when they're planning ahead for their families. I didn't put this in any specific order. I'm not trying to say that one is a better option than the other. I just had to put it in some order. The first option that I have here is disqualification before dating. This really would only work in certain communities where people compare their genetic results before they even go on a first date, which is commonly seen in the ultra-Orthodox Jewish community. But that's pretty limited for this one. Other couples might already be dating each other, and they might decide to break up and just not have kids together at all, so they don't have to deal with all these other different options that they have. Some carrier couples might decide not to have children at all. They might stay together but not have kids, or they might decide not to have biological children. They might adopt. Other families might decide to use assisted reproductive technologies. So for example, they might use a donor egg or a donor sperm, who is obviously not a carrier for the condition, but then you don't have to worry about both parents passing on any mutations to the kids. Another option that couples have are to take a chance. They know that there's a 75% chance with each pregnancy that the child will not be affected, and a 1 in 4, 25% chance that the child will be affected. So they might decide to just roll the dice and see what happens. A couple who decides to roll the dice could also have the option to test a baby during a pregnancy. So I'm just going to switch to the next slide to show you a picture of how you would test a baby during a pregnancy. We call this prenatal testing. So that means you're already pregnant and you're testing the fetus to see whether or not it's affected with the condition that we're concerned about. So there are 2 different tests, or 2 different ways you can test a baby. One of the tests is called the chorionic villus sampling, or CVS for short. The other one is called an amniocentesis. I put a slash here because I'm not an and sign, because you don't do both tests. You do one or the other if you want to find out during the pregnancy what the status of the baby is. If you're doing a CVS, basically the doctor takes a needle, puts it through the belly, and takes out a tiny, tiny bit of the placenta. Whatever is going on in the placenta should reflect what's going on in the baby. So it's basically a way of getting baby cells without touching the baby. The other test I have here in amniocentesis is the same idea, where the doctor takes a needle and puts it through the woman's belly. But instead of taking placenta, they take out some amniotic fluid that the baby is floating in. Same idea, there are baby cells floating around, like basically dead skin cells in the amniotic fluid, and they can send that off to the lab and tell us whether or not this is a baby who's affected with the condition. Most people don't do both. As I mentioned earlier, you do one or the other. The CVS can just be done earlier on in a pregnancy, so you can get your results rather early if you know that you're a carrier couple. For couples who find out that they are carrying a baby who's not affected, that's great. They don't have to worry about it anymore for the remainder of the pregnancy. But for couples who find out that the baby is affected, they would have the option to continue the pregnancy, to take the rest of the time to learn about the condition, maybe find providers who will be helpful for them, and do their research and prepare, to have a child with the condition. And in other cases, they might decide to terminate the pregnancy, and that's, as we all know here, is very state by state right now and very political. So we don't need to go into too much detail about that, but in many states, it is an option to terminate a pregnancy. The last option that I have here is called in vitro fertilization. So some of you might have heard of IVF or in vitro fertilization before. Most people have heard of it more in the context of fertility issues. So, you know, when you have a couple who's having trouble getting pregnant on their own, very often they turn to IVF or in vitro fertilization to get pregnant. What does an IVF cycle look like? Basically, the woman gives an egg sample, the man gives a sperm sample, and they fertilize it together in the lab. So they create an embryo in the lab. They let that embryo grow for a couple of days, and then they take it and they implant it into the woman's uterus, and hopefully she gets pregnant with that embryo. What I'm suggesting here, when we know that there's a risk for a couple to have a child with a genetic disease, is they would undergo the exact same IVF process, but they would add in one step along the way called pre-implantation genetic testing, or PGT. What that is towards the very end of the process, after the embryo has grown for a couple of days, they take out, here's a picture of them like sucking it out with a pipette. They take out a few of the cells of the embryo, and they can do genetic testing on the embryo. If they see that it's an embryo that is unaffected, again, 3 out of 4 or a 75% chance, they'll take that embryo, they'll implant it into the woman's body, and hopefully she'll get pregnant. And it's going to be with a child that we know for sure does not have the condition. If they see that the embryo is affected with the condition, they will discard it in the lab and it will never become a baby. So it's basically a way of avoiding getting pregnant at all with a baby who's going to be affected with the condition. So as you can see, there are many, many options for carrier couples. It wasn't always this way. In the early days of genetic testing, they used to recommend that carrier couples just break up or not have kids because we didn't have all of these assisted reproductive technologies that we have today. But nowadays we have a lot more options, you know, for couples who are already pregnant or for couples who are pre-pregnancy. And that's why I highly, highly recommend that people get tested before a pregnancy, because just in case there's a problem, they'll have more options if they're not already pregnant. So if you're already pregnant, most of these things are not options anymore, right? Really the only option is to take a chance. But if you're not already pregnant, you have way more options available to you. So who should get carrier screening? Really anybody. Anybody who's planning to have a family. Doesn't make a difference what their ethnic background is, as I mentioned before. It doesn't make a difference if they're interfaith, where, you know, one partner is fully Jewish and the other one isn't. Even if they're not Jewish at all, you know, you can have a Hispanic couple. They need to get tested too, because as I said earlier, anybody could be a carrier of anything. Same goes for same-sex couples and couples who are using egg or sperm donors. It takes two to tango. So whether it's your social partner or your reproductive partner, anybody planning to have a child needs to get tested. In the US, you must be at least 18 years old. Is everybody here from the US? Yeah, I think so. Yeah.
We have one Canadian.
One Canadian, okay. I will try to address the Canadians, but I don't know much about them, sorry. Okay, so when should screening occur? I mentioned earlier, before a pregnancy is always better than during a pregnancy. Even though technically one can do the test during pregnancy, the results will be the same. It's always better to know beforehand. And the timing of that can be different among couples. So, you know, Rachel mentioned that she did it when she was already married and ready to have a child. Some people do it after they go on a first or second date. Some people do it the day before they're about to get engaged, and then they call me and say, please expedite the results. I need to know. You know, it doesn't really make a difference to me as long as it's before pregnancy. Where can you get screened? In the US, I put JScreen first because I work for JScreen, so I'll talk to you a little bit about it in more detail. Some people will go to see a genetic counselor in their office. This I would recommend for people who have more than just, I want to have testing because I'm going to have a baby on their mind. So let's say there's a family history of something and additional testing that relates to their particular situation might be warranted. They should go see a genetic counselor and not just do a standardized test like JScreen. Some people will go to their doctor to order their test, either their internist or their OBGYN. I think this is fine, but I will warn you that OBGYNs specialize in OBGYN. They do not specialize in genetics. So I have unfortunately seen many cases where people had their doctor order their test for them, but the test that they ordered was not up to par with a test that they can do at a genetics person, whether it's a genetic counselor or through JScreen. You know, these doctors are not so up to date necessarily on what's out there, and they might be ordering outdated testing. So it's fine to get tested by a doctor as long as you're aware that the doctor is testing for a very thorough and comprehensive panel of diseases. So it's okay to ask, if they say, yeah, we're testing for all the Jewish diseases, all 18 of them, that's not good. You want to hear hundreds of diseases. You don't want to hear 18 or a number like that. Some people, or many people, actually ask me about 23andMe. You probably all have heard of 23andMe, which is a direct-to-consumer test. It sounds similar and smells like JScreen, but it's not. So 23andMe is a direct-to-consumer test where they take a saliva sample, send it off to the lab, and then they tell you different pieces of information. So they tell you about your ancestry breakdown, which is kind of interesting and kind of cool. They tell you about certain genetic predispositions that you might have that have nothing to do with traits. I'm sorry, that have nothing to do with disease. So just traits like, are you pale, or are you right-handed or left-handed? Things that have nothing to do specifically with health-related topics. And then they also give you genetic information that is related to your health. They test for a number of different genetic conditions to see if people are carriers. I'm not sure if Usher 1F is actually on their panel. I should look. It is. Okay. They test for, I don't know how many, 20 or so different conditions. This is not the same as JScreen. It is not a medical grade test. There is no genetic counselor. They're interpreting results. They are testing for a very limited number of diseases. Just to compare, we're testing for 225. They're testing for 20-ish. And in addition to that, the technology that they use is it's not good. It's very old school, and it could be a lot better. So 23andMe is great for the fun stuff, the recreational stuff like the ancestry and the does cilantro taste like soap to me kind of stuff, but it is not recommended for health-related things. So for health-related things, go to a health professional. Outside the US, things are a lot more complicated. I'm sorry to our Canadian here. I don't have much more information. We cannot accept samples from outside the US at JScreen, but I know that there are options for screening in Toronto and Montreal, and especially in the areas that are heavily populated with Jews. I know that they're very up to date with their testing. It's just not something that I can help with. And that's it on reproductive carrier screening. So by now, you should all understand what we're doing with the testing, the point of the testing, who should get tested, when and how to get tested. And now I will introduce you to our cancer screening program. And then after that, I will tell you exactly how JScreen works for both our reproductive carrier screening and our cancer screening program. So our cancer screening program is totally separate from our reproductive carrier screening. We use two different labs, two different samples. They are completely separate from each other. The only thing that they have in common is that they're both genetic tests. So when people go to our website and they sign up, they pick one or the other. Some people actually choose to do both, but you don't get your cancer results with your reproductive carrier screening. They're totally separate. So what is cancer screening? So not all cancers are genetic. Actually, most cancers are not genetic, but some are. So, this got cut off. This is supposed to say sporadic. But if you look at all the cases of cancer, only a very small piece of the pie is hereditary. It's due to genes that are running in the family. If you were to zoom in on those hereditary forms of cancer, there are a couple, or I don't know, 50, 60, 70 different genes that could cause these hereditary cancers. Now, when somebody has a mutation in any of those genes, what that means is that they are predisposed to cancer. So earlier on, when I was talking about the different types of genetic tests that we do, the third one there was predisposition testing. So when somebody tests positive, they don't necessarily have the condition, but they're more likely than others to get the condition. So with the cancer genes, this is somebody who doesn't have a mutation in a cancer gene. They have a risk to get cancer because everybody on the planet has a risk to get cancer. This is somebody who has a mutation in one of the cancer genes. Their risk to get cancer is even higher. So depending on which gene we're talking about is always a different conversation, but overall, having a genetic mutation in a cancer gene causes somebody to have a higher than normal chance to develop cancer. I'm going to use the BRCA1 gene as a good example. So the blue bars are people who are in the general population, people without a BRCA1 mutation, and the green bars are people who do have the mutation. So female breast cancer, the risk for an average woman to develop breast cancer is about 12%. It's a pretty common cancer. But if somebody has a mutation in the BRCA1 gene, that risk is about 88%. Ovarian cancer, not as common as breast cancer, about 0.5% or 1.5% of women get it. But if they have a BRCA1 mutation, that risk is up to 50%. Same thing for pancreatic cancer in males and females, and in males, male breast cancer and prostate cancer. So when somebody has a mutation in their BRCA1 gene, they are predisposed or more likely than others to get these cancers. you'll see that none of these are 100%, right? Nothing goes all the way up to 100. So it's not a guarantee that somebody who has a mutation will get a cancer, but the risks are just, significantly higher than people who do not have a mutation. Now, when somebody tests positive, when we learn that they have a mutation, they sit down with a genetic counselor, such as myself, and we talk about, what can you do with this information now that you have it? So often there is a lot that they can do. So for some people, they might decide to be a lot more vigilant with their cancer screening so that if they're going to get cancer, they're going to find it at a much earlier and more treatable stage. So that might mean, doing more imaging like breast MRIs and breast ultrasounds instead of just mammograms. It might mean doing colonoscopies at an earlier age than typically somebody might do, et cetera. Those are just some examples, but depending on which gene it's talking about, there are extra screenings that people might do, or maybe they'll even start doing at a younger than typical age. In some cases, we also talk to people about doing preventative surgeries, where if they remove certain parts of their body, they don't have to worry about getting cancer in those areas. So, for example, with a BRCA mutation, we recommend that all women who have a BRCA mutation remove their ovaries by the time they're age 40 or by the time they're done having kids, whichever one comes first. The reason being that there is no good screening for ovarian cancer, so we don't want to miss it. And that's why we say it's better to just remove the ovaries than to worry about something growing that we can't even find. In some cases, people will do genetic testing when they already have a diagnosis of cancer, because if they have a specific result, that can help us decide which type of chemotherapy or other surgeries might work well for them. So sometimes we test people who already have a cancer diagnosis because it can help with their treatment plan. And also, we discussed IVF before, when they create the embryo outside the body and they can do genetic testing on it. They could do that for Usher 1F, they could do it for Tay-Sachs, and they can do it for BRCA too. So it doesn't make a difference what type of genetic disease we're talking about. When somebody has a mutation, they potentially could stop it from continuing on to the next generation if they decide to use IVF. And really, even more important than all this is you can save other people's lives too. So when we find out that we're positive, or when somebody finds out that they're positive, we tell them who in their family should know this information and should consider getting tested so that they would have all these same options as well in case they test positive. So it's very empowering for people who find out that they're positive, because they have a head start now and they can, be proactive instead of being reactive to a diagnosis. So who should get tested? Historically, we only tested some people for cancer genes, people who had histories, either personal histories or family histories that were very suggestive that there's something genetic going on. And that was because it was really, really expensive to do the testing, and the insurance companies didn't really want to cover it. Nowadays, we don't believe that we should be limiting our testing anymore, and we offer it really to anybody who wants the information. And now we have some really great affordable options with and without insurance. So that is our carrier screening test and our cancer test. As I mentioned earlier, both of these tests can be done at JScreen. If you go to jscreen.org, this would be a screenshot of our website. You can see that you can choose between our ReproGen test and our cancer gen test. The ReproGen test is the one where we do reproductive carrier screening for Usher and Tay-Sachs, et cetera. And we're testing for 225 genes. Our cancer gen test is for BRCA and the other cancer predisposition genes. We are currently testing for 63 genes, and we're bumping it up to 73, I think the beginning of April. We'll be testing for 10 more. The way that we do our testing is the same for both our Repro and our cancer gen tests. People go onto our website and they request a spit kit. As they register, we ask them about a little bit about themselves, any history that they might have. We also get their doctor's information because we need to get their doctor to sign an order for them, and we facilitate that. And we also ask for insurance information. The price of the test is quite reasonable. It costs $149 to do the ReproGen test and $199 to do the cancer gen test. For people who do both, there's a combo price that's a little bit cheaper. Then we ship them their kit, they spit into the tube, they send it back to the lab. And then when the results are ready, we receive them at JScreen. We let our patients know that the results are ready, and we have them sign up for either a genetic counseling session over the phone or by Zoom, whatever they want. And after we speak to them, we email them the results, and we send them to the doctor as well. And in cases where we think, extra medical attention needs to be taken, we get in touch with their doctor and, make sure to speak to them on the phone just so that they know exactly what's going on. And, very often I'll have patients who need to see specialists in their area. And I live in New York and I don't know every single specialist in every single area. My patients are all over the country. So I rely on their doctors, to help me set them up with the right people for their location. So the doctor is part of the whole process and we'll get a copy of the results. So it's not a 23andMe test. It's done with a medical model. We are actually based out of Emory in Atlanta. So our two division heads, our cancer gen and our repo gen heads, are both geneticists at Emory. So we are totally backed by them and by their Department of Human Genetics. So the key points for tonight, anyone who is planning on having a child should have carrier screening before pregnancy is ideal. And there are options for carrier couples, for at-risk couples. Just going back to the cancer testing, it can really help you and your family get ahead of the risk. And here is my contact information if anybody would like to reach out to me, if anyone has any private questions or just anything you want to talk about, this is how you can reach me.